All right, we'll go ahead and get started. So, hello everyone. Happy Vitiligo Awareness Month. My name is Rachel Krebs, and I'm a social media liaison at Global Dermatology Talks. Today, Global Dermatology Talks is thrilled to welcome Professor Julien Seneschal from the Department of Dermatology at the University Hospital of Bordeaux in Bordeaux, France, as he talks about a new perspective in vitiligo regarding research and therapeutic development. We also wanted to briefly share that our patient advocate, Mrs. Gaune Matewa from the Vitiligo International Patient Organization Committee, will not be able to attend today due to an illness, but we wanted to briefly share her organization on a screen share just to talk about it. So this is a website from VPOC, the Vitiligo International Patient Organization Committee. It is a patient advocacy group based in Europe. And let's see here. It is a worldwide alliance of vitiligo patient organizations that was built in 2018 during the first Vitiligo International Patient Organizations Committee conference, and is now an official non-governmental organization and patient advocacy group in Paris. And we would just like to highlight that they have an upcoming event in Cairo this December 13th through 15th. So now I'd like to welcome Professor Seneschal. Julien Seneschal is a professor of dermatology at the Department of Dermatology at the University Hospital of Bordeaux and the National Reference Center for Rare Skin Disorders. He is responsible for managing the Skin Inflammatory Disorders Unit and the Vitiligo Clinic. Following a postdoctoral fellowship at Harvard University, where his research focused on skin immunology, he established the immunodermatology team with the aim of gaining a better understanding of the immune pathogenesis of vitiligo. He has authored numerous clinical and research articles on skin inflammatory diseases and vitiligo, which have been published in reputable journals such as the Journal of Investigative Dermatology, Journal of Allergy and Clinical Immunology, Science Translational Medicine, and Immunity. Julien Seneschal previously served as a board member of the European Society for Dermatological Research and was the past president of the French Society for Research in Dermatology. Currently, he serves as the co-coordinator of the Vitiligo Task Force, which recently published worldwide expert recommendations for the diagnosis and management of vitiligo. In recognition of his contributions, Julien Seneschal has received awards from the French Society for Research in Dermatology, the Roche-Posay European Foundation Award, and the Charles Grupper Leo Pharma Award. Welcome, Professor Seneschal.
Thank you very much. Thank you very much. Hi, everyone. Thank you very much for this very kind introduction. So I'm going to share my screen here. So here with this beautiful picture of the center of my city, Bordeaux, probably most well known for the wine, but it's also a beautiful city in France if you want to visit. So I'm going to talk about vitiligo and new perspective from research to therapeutic development. But I'm going to start with some introduction about the disease and the impact of the disease and to understand why it's so important to recognize the disease, because June is the month of vitiligo, June 25, the World Day of Vitiligo. And then I will present all the development of new therapeutics in vitiligo regarding the new understanding of the immune pathogenesis of the disease. So here are my disclosures. And first, probably you know about vitiligo. Vitiligo is a chronic inflammatory autoimmune skin disease leading to the presence of white patches. And there is a different form of the disease, what we call the non-segmental vitiligo. And there is different subtypes of the non-segmental vitiligo called the generalized pattern, where lesions are located all over the body, and what we call the acrofacial pattern, where lesions are mainly located on face, hands, and feet. There is also segmental vitiligo, and sometimes in some patients it could be mixed with a segmental pattern as here, and then lesions located on the rest of the body, mucous pattern on the aloniva, classically associated with vitiligo. What will be very important in vitiligo, it will be for the treatment, will be to recognize patients with a stable disease or patients with active disease. And this patient with a truly active disease will need treatment as an emergent treatment to stop the spreading of the disease. So it's so important to recognize this patient with active disease. But I will show you how to recognize these patients. So my first, let's start with the prevalence of vitiligo worldwide. Here is a paper recently published in Lancet journals. It's a worldwide study in collaboration with people from Europe and South Korea. And the group of experts is in a group called the Global Vitiligo Atlas. And this work, it has been done with the data coming from cohort studies, but also all the literature published in the field of vitiligo. And they found that the global lifetime prevalence of vitiligo was 0.36 in the general populations. And it was a little bit higher in the adult population compared to the child populations. And Central Europe and South Asia reported the highest prevalence of vitiligo. So it was really important work showing the prevalence of vitiligo. Regarding the in Europe, based on real world coverage, the prevalence of vitiligo is between 0.2 and 0.8% of the general populations. So why is so important to recognize vitiligo as a true disease? Vitiligo is not just like a cosmetic disease. We don't like this word, cosmetic disease, because vitiligo is associated with important impact on the quality of life of patients. And here is all the impact that could be associated with vitiligo, such as stigmatizations, relationship difficulties, suicidality, or cognitive impairment. And all these are associated with vitiligo and truly impact the quality of life of the patients. And here is to show how vitiligo can impact the patients. In some countries, having vitiligo could, for some patients with vitiligo, these patients are ejected from some work. And it's a comment in a Lancet journal coming from data from Brazil, where patients with vitiligo are not accepted in some public work. Which factors are associated with a great impact on the quality of life of the patients? The age at onset of vitiligo, we know that early onset in childhood and adolescence is associated with low self-esteem in adulthood. The skin types, we know that the impact of vitiligo is higher in patients with darker skin, and the localization and the extension of the disease. Of course, having vitiligo on the face, on the hands, is truly associated with high impact on the quality of life. And here is a paper we have done with my colleagues in France, Professor Khaled Ezzedine, and they show that when they compare the self-assessment of vitiligo at one time and then 1 year later, they found that an increase in facial extent was statistically associated with the patient's perception of deterioration, meaning that the presence of lesions located on face is associated with high impact for the patients. Here is another study. It's a multi-center study based on it's a questionnaire that has been sent to patients, but also healthcare professionals. So you can see that more than 3,500 patients were included, but also healthcare professionals. Mainly, the median age was 38, and with a good representation of patients with fair skin or dark skin. And you can see that, again, the factors associated with impact on the quality of life of the patient were exactly the same I said before, was an extent of the disease more than 5% body surface area involved, darker skin, and presence of lesions located on visible areas such as face and hands. What was important is that vitiligo was often misdiagnosed as during the first visit, and always we know that vitiligo can be misdiagnosed with some skin other diagnoses such as skin damage, fungal infection, or atopic eczema, what we called pityriasis alba. And 16% of healthcare professionals reported having frequently encountered patients who were previously misdiagnosed while they were while they are truly vitiligo. And that meaning that the average time to receive a correct diagnosis is very long, 2.4 years. Here is a percentage, 65%. And what is this percentage? Is 65% of patients with vitiligo in Europe have been told that their condition was untreatable. And now we think with the development of new treatment, I think now it's time to change this view. And you can see that in France, in my country, it was 75% of the patients with vitiligo who have been told that their condition was untreatable. And the top goal of treatment for vitiligo for the patient and healthcare professional was reduce the stop the spread of the disease to get good repigmentations and improve the long-term clinical outcome of vitiligo. So now I think I show you that it's really important to recognize vitiligo as a true disease. And of course, over the past years, vitiligo has been truly neglected with and everybody thought that there is nothing to do for this condition because, of course, there were no cure or way of restricting the spread of the disease, and all the treatment until now have been used off-label, such as topical calcineurin inhibitors, topical or systemic therapies, or UV lights. But now, with an increasing number of papers with better understanding of the immune pathway of the disease, led to the development of new treatment, and now there is an approved treatment for vitiligo and many development of biologics and targeted therapies. So what is the immune pathogenesis of vitiligo? Vitiligo is a complex disease involving combinatorial factors, and we know that there is genetic factors, and many genes associated and found associated with vitiligo are related to protein associated with the immune system for 90%. Some genes are associated with melanocytes, and in predisposed patients under environmental triggers, there is an increased response of the immune systems leading to the loss of melanocytes. And we know that vitiligo is a true autoimmune disease because here is a simple observations. When you take a skin biopsy at the perilesional skin of the patient, you can clearly observe the presence of inflammations as shown here with the CD3 staining. And you can see in the perilesional skin, there is inflammations and the presence of these cells, while in the lesional skin, there is complete absence of melanocytes here in the basal layer of the epidermis, but there is still some presence of some cells located in the dermis or in the epidermal layer. So vitiligo here, what are the initiation triggers of the disease? We know that in a genetic predisposed patient, under environmental triggers, the epidermal cells, keratinocytes and melanocytes can respond to this triggers that could be stress, friction, or chemical damage. And melanocytes, as keratinocytes, could increase the level of oxidative stress, could increase the expression of danger signals such as heat shock protein 70 or HGMB1, can produce pro-inflammatory cytokines and chemokine ligands that could help the recruitment of population of immune cells. So here is a classical view of the immune pathogenesis of vitiligo in the genetic predisposed patients under environmental trigger. So the epidermal cells can produce danger signals that will lead to the activation of immune cells, innate immune cells, such as innate lymphoid cells and plasmacytoid dendritic cells. And these cells, innate lymphoid cells, can produce large amount of interferon gamma that will impact melanocytes, and PDC will produce interferon, type 1 interferon alpha, that will lead to the production by keratinocytes of ligands called CXL9 and CXL10, leading to the recruitment of T cells coming from the blood, producing a large amount of interferon gamma and TNF alpha. But now we know that there is a population that has been recently described more than 10 or 15 years ago called the resident memory T cells, and we know that these resident memory T cells can play a role in vitiligo. They are present in the skin of patients with vitiligo, and these T cells can produce large amount of interferon gamma and TNF alpha. Of course, the presence of resident memory T cells can explain these observations. Here, in the patients with active vitiligo, you receive a systemic treatment in combination with UV light and show very good repigmentation after 6 months. But the patient was lost of follow-up and came back 8 months later after stopping the treatment. And you can see that these patients recur the disease at exactly the same sign than previously affected. And we know by observation that almost 50% of patients develop vitiligo lesions on areas that have been repigmented by treatment after 1 year. And this observation could be explained by the presence of resident memory T cells still present in repigmented area. And these cells can produce large amount of interferon gamma and TNF alpha and are under the maintenance of these T cells is dependent of one cytokine called IL-15 that can be produced by keratinocytes. And this cell has been described by many groups, including John Harris and Julien Richmond, but also our group, as T cells present in vitiligo skin that could play a role in the initiation and in the recurrence of the disease. These cells, again, here in patients with a lesional skin with active vitiligo, there is an infiltration of these T cells, resident memory T cells, but also T cells coming from the blood. But even if the patient got very good repigmentation, we know that there is still the presence of these resident memory T cells in the skin that can be activated to induce new lesions or the recurrence of the disease on previously affected skin in almost 50% of the patients that stop the treatment, meaning that there is probably a need for maintenance therapy in patients who got very good repigmentation, but I will talk about that later. Here is some classical markers associated with memory T cells, melanocyte-specific T cells in skin. We know that these memory T cells could express some specific markers, CXTR3 or NKG2D in vitiligo. They express classical marker of residency, such as CD103 or CD69, but another one, CD49A, has been specified specifically associated with melanocytes specific T cells, and these cells produce large amount of interferon gamma. And these cells are under the dependence of IL-15 or IL-2 family member cytokines, and you can see that this receptor is dependent of the JAK-STAT pathway. Here is another paper coming from John Harris group showing using single cell RNA sequencing here, and that they look at all the different populations in vitiligo skin, and they found that there is a population of CD8 positive T cells, cluster of these cells expressing CCL5, and CCL5 could interact with some population of Treg expressing CCR5, and probably the expression of CCR5 on regulatory T cells. We know that these regulatory T cells can control the inflammation, or probably the expression of CCR5 is probably important for Treg to be to colocalize with CD8 and probably play a role to control the activation and the proliferation of this specific CD8 population in vitiligo. We know that vitiligo is mainly associated with the production of pro-inflammatory cytokines, interferon gamma and TNF-alpha, but is it just a type 1 immune response, skew immune response? Actually, we observe that the T cells out of the skin of patients with vitiligo can produce pro-inflammatory cytokine associated with the type 1 immune response, interferon gamma, but we also found that these cells can produce type 2 immune-related cytokines, mainly IL-13. And probably this type 1 and type 2 cytokines can impact both keratinocytes and melanocytes to induce the loss of melanocytes. So vitiligo is not just a type 1 skew immune response, but involves also other pro-inflammatory cytokines, such as type 2 immune cytokines, IL-13. Next, what is the loss of melanocytes? So of course, it's easy to say that the melanocytes are killed by the immune systems, probably by the action of interferon gamma, but probably also by the release of cytotoxic molecules such as enzyme B or perforin. But we came with another hypothesis that the melanocytes are lost following their detachment from the basal layer of the epidermis. And of course, we found that in patients with vitiligo, we can clearly observe the presence of melanocytes, as shown here, detached from the basal layer of the epidermis. And we found that actually the pro-inflammatory cytokines, interferon gamma and TNF-alpha, as shown here, can induce the expression of a matrix metalloproteinase 9 called MMP9 by keratinocyte, and this MMP9 is able to cleave the E-cadherin. The E-cadherin is a protein responsible for the attachment of melanocyte to the basal layer of the epidermis. So the increased expression of MMP9 induce a cleavage of E-cadherin, and the soluble E-cadherin can be detected in the serum of patients with vitiligo, and melanocytes are probably detached from the basal layer of the epidermis and lost from the epidermal layer. And then we know that in vitiligo there is a defect of regeneration of melanocytes. Another paper from Thierry Passeron's group confirm our result and shows that classical factors, environmental factors, we know these environmental factors in atopic dermatitis. It's the role of house dust mite, and house dust mite is able to induce the production of MMP9 to induce the destabilization of melanocyte and to induce the loss of the detachment of the melanocyte from the basal layer of the epidermis. And here is skin treated with house dust mite, and you can clearly see here the detachment of melanocytes, and house dust mite is able to induce the production of NLP9 by keratinocytes, suggesting that these classical environmental triggers can also play a role in the detachment of melanocytes. A paper coming from China was very interesting because it explained maybe why some chronic skin disease, such as vitiligo, the lesions are often symmetrical, and they actually found that there is a different population of fibroblasts, and in non-lesional skin of patients with vitiligo, and they did that of many mouse model, they found that in non-lesional skin there is a presence of fibroblasts that are not responsive to interferon gamma, while in the perilegional skin of patients with vitiligo, there is a presence of fibroblasts, prime fibroblasts that are very responsive to interferon gamma and can produce ligands, CXL9 and CXL10, that can induce the recruitment of T cells expressing CFR3. And these fibroblasts are differently present on the skin of patients with vitiligo. Another point is, of course, we know that there is different factors that can induce the loss of melanocytes, but after there is also a defect of regeneration of melanocytes. And today, the only treatments that can induce the proliferation, activation and proliferation of and differentiation of melanocyte stem cells is the sun, and sun exposure is really important as a treatment for vitiligo and can induce the differentiation of melanocyte stem cells from the hair follicle. But Thierry Passon's group showed that there is also a defect on pathway called the Wnt beta-catenin pathway that is reduced in melanocytes, and if you increase the expression of this pathway or restore this pathway, you can induce the differentiation, proliferation of melanocyte stem cells to melanocytes, and probably it could be something really important as a treatment strategy in the future to induce the regeneration of melanocytes in vitiligo. So now, after talking about the disease, how the disease could impact patients, and the understanding of the immune pathogenesis of vitiligo, is it possible to achieve very good repigmentations in vitiligo with older treatments or new therapeutic strategy? I show you that because of the presence of resonant memory T cells in vitiligo, it's probably important to get like early interventions in vitiligo to avoid the accumulation of resonant memory T cells in vitiligo that could play a role in the recurrence of the disease. It's the goal of what we call the ERAS project. We have done this project. We have done that with in collaboration with Thierry Passeron to respond to this question if strategy with a systemic treatment and UV lights in patients who started their disease in the last 6 months can change the course of the disease. And I show you, because of the presence of resident memory T cells, it's probably important to consider a maintenance therapy to avoid the recurrence of the disease. So the 3 objectives in vitiligo treatment is probably to stop the spreading of the disease, the spread of the disease, to induce very good repigmentation, and then to prevent the relapses and to maintain the repigmentation. So just I would like to share with you the important recommendations we have recently published with the international group of experts on vitiligo. It has been published in last October in the GADV journal. It can be also it it's an open access paper, so you can download the paper easily. So there is a part one that describes the disease and shows the management algorithm. And there is also part two with specific recommendation with the use of different treatment for vitiligo. And what the algorithm is, there is 4 levels in the algorithm. So there is, it's part one of the paper. So the diagnosis, the shared decision making, assessment of disease activity, and treatment option. And here is a different algorithm in vitiligo. So first we came with what we called, what is really important in vitiligo is the shared decision, the shared decision. So we can always discuss with the patient how to treat the patient, what are the different objectives for the patients. Is it to stabilize the disease, to get good repigmentation, or maybe to induce to induce what we don't want, to get depigmentation? So in case of when the objective is to stabilize the disease, you can consider systemic treatment. I will show you later, for patients with really active disease, or to combine topical therapies, topical steroids, tacrolimus, and or ruxolitinib with UV lights. And if a patient is stable, want only to control the disease, to make the disease stable, you can consider to get like a maintenance therapy and to use topical treatment twice a week. If you want to, if the goal is to induce repigmentations, you have to combine the treatment, topical calcineurin inhibitor, topical steroids, and topical ruxolitinib, but you have to combine with UV lights. And if the patient is stable for more than 12 months, with no efficacy of systemic and topical treatment, and if the patient have a very limited lesion, you can consider melanocytes grafting. And of course, after, you can consider some depigmentation with patients with very extensive disease, and there is different options such as monomazone or pigment laser. So it's really important that the physician can recognize the importance of this disease. You can also, we talk about the patient support organizations that are really important to help the patients with some educational support, with information leaflets. And it's important to talk with the patient about the existence of these patient support organizations that are very, very active in US, Asia, and Europe. So for this algorithm that highlights the importance of the shared decision making, it's really important. Assessment of the disease activity is really important to recognize a patient with a sign of disease activity, and we'll show you what are the signs of disease activity. Important to avoid misdiagnosis and detection of early aggressive disease, to start active treatment and offer psychological support for the patient. What are the key messages of this expert recommendations? Always try to combine treatment. Combination of treatments is generally more effective. So combination of anti-inflammatory drugs with UV lights. Topical corticosteroids could be used for prolonged use, could be used like once a day, but for 3 months, or sometimes 3 times a week. Topical calcineurin inhibitor can be used as a maintenance therapy. We know that there is now, we can, ruxolitinib cream is approved for vitiligo and can be used, and I will show you later. It's important to consider maintenance therapy in patients who got very good repigmentation, especially on face, by using biweekly application of topical calcineurin inhibitor, or topical corticosteroids, or topical ruxolitinib, even if it has not been really proven twice a week. You can combine with narrowband UVB, and at least for 3 to 6 months. And we can use systemic treatment, especially for patients with active treatment, with active disease, to stop the spread of the disease. Um, it's important, as I mentioned before, to recognize a patient with an active form of the disease. Here, you can see here the patient who came to my clinic here, and she did not really want a systemic treatment to stop the spread of the disease. So she didn't want any treatment, but she came back to my clinic just as to get a clinical exam after 6 months, after 1 year, and you can clearly the spread of the disease after 1 year. So it's important to recognize the sign of this disease activity. And what are these signs? You can clearly here see the presence of what we call the confetti lesions. Confetti-like lesions is very small depigmented macule located around the vitiligo lesions, and we know that these lesions are really active. You can see the presence of friction, it's Koebner phenomenon type 2b, and we call here also the presence of the trichrome area, where there is a lesion very white, the normal skin very the color of the normal skin, and there is a brownish area here where the lesion the skin is not completely depigmented, and these three signs are really the sign of disease activity. And for this patient, you have to consider a systemic treatment. And now what we use, it's mainly oral mini pills. So I use oral methylprednisolone twice a week for at least 12 to 24 weeks. We can consider, even if there is low data, some systemic treatments such as methotrexate or cyclosporine, but you have to consider, but these treatments often stabilize the disease. But if you want to get good repigmentation, you have to combine that with narrowband UVB twice or 3 times a week for at least 6 months. If you want to prevent the relapse of the disease, what has been published is the use, especially on face, the use of tacrolimus ointment twice a week, and that decrease the risk of relapse from 40% to 9%. So that in 90% of the patients maintain their disease by using a topical anti-inflammatory drug. It could be tacrolimus, probably it could be the same with topical steroid, it could be the same with topical ruxolitinib, even if it has not been proven or published, but it has been published with tacrolimus using twice a week. 90% of the patients maintain their disease, especially on face. You can use UVB 2 or 4 times a month, but it has not been really published. It's only expert opinions. So now it's looking at innovative therapies because now we better understand the immune pathologies. We know the role of interferon gamma, and we know that interferon gamma, the signaling of interferon gamma is dependent on the JAK-STAT pathway. So that's why JAK inhibitors is under the development for vitiligo. We know that topical ruxolitinib, JAK1 and 2 is now approved for vitiligo, but systemic treatment and systemic JAK inhibitors are currently developed in vitiligo, and I will show you later some results regarding the use of systemic JAK inhibitors in vitiligo. So for those who are not aware about vitiligo, here is a classical outcome or scores used in vitiligo. We call here VASI. I will talk about VASI or facial VASI. So VASI score, it's that the extent of the disease is based on the palm the palm unit, 1% BSA, and you apply to the extent of the disease an atlas of depigmentations. So it's a composite score, and there is, so here is for the total VASI for the body, and there is also development has been validated, the facial VASI, exactly the same thing, but only for the face. So I will talk about facial VASI and T-VASI. Sometimes but we know that assessing the score of vitiligo is not always easy, especially between investigators. So we develop, but other experts develop assessment of vitiligo using artificial intelligence. So we took our picture of patient with vitiligo and we developed an algorithm of artificial intelligence to assess the degree of depigmentations before and after treatment, but others develop similar methods to assess the face of vitiligo without using a score. So I will talk about ruxolitinib cream. Now it's approved, so I will go only about some key messages related to the long-term use of ruxolitinib. But let's start with the two phase 3 study evaluating the efficacy and safety of ruxolitinib. So during the first 24 weeks, patients receive ruxolitinib cream or placebo, and then all the patients receive ruxolitinib cream. What we say to the patients who want to start ruxolitinib cream it's always after at least 6 months of treatment or after 1 year. And here you can see that we say to the patient that more than 50% of the patients got more than 75% improvement on the face, and 30% of the patients got more than 90% improvement on the face. And here a classical example of patient who got very good response at baseline and then after 1 year. You can get a good response on the body. And you can see here that more than 50% of the patient after 1 year application twice a day got more than 50% improvement of the lesions located on the rest of the body. So it's important to say that to the patients. And here is some good example of good response after 1 year on lesions located on the body. We know that there is still some area very difficult to treat for the patients, such as hands and feet, and it's important to mention that to the patients because it's not like a miraculous treatment, and we know that there is still difficult part of the body that do not respond to the treatment. Here is some other example of good response with application of topical ruxolitinib twice a week. The tolerance of the treatment is very good. You have to consider to the patient that it's important to say that there is the patient they could develop some acneiform reaction in 4% of the patient after 1 year of application. So what is now important to mention is a long-term extension study. So what happened after 52 weeks if the patient still applies the treatment for 108 weeks? So we know that the 70% of the patients who continue application of ruxolitinib cream maintain the treatment, maintain the response to the treatment. So it's really important to say that the patient, if they still continue the treatment, they will maintain the response. But if they stop the treatment, the response will be maintained in almost 40% of the patient. That means that 60% of the patient, after stopping the treatment, will lose this response, facial VASI 75. So it's really important to say to the patient that if they stop the treatment, the disease will come back. And here is the maintenance therapy in patients who continue the treatment compared to the patient who were on placebo, who stopped the treatment. But if the patient stop the treatment, lose the response, if the patient start again the response, it's important to say to the patient that they will regain the efficacy. And 75% of the patients regain facial VASI 75 after 12 weeks, or facial VASI 90 after 15 weeks, when they will start again the ruxolitinib cream twice a day. What is really important, there is no, even after 1 year of application, there is no plateau effect. If the patient continues the treatment, there is still some patients who got very good response. 33% of the patients applying ruxolitinib cream twice a day achieve facial VASI 90 at weeks 104. So it's really important to say that the patient, it's a very long period of treatment needed to achieve very good response. Regarding, because ruxolitinib cream now could be used for patients, it's approved, it's commercially available in US, in Europe, but there is, for patients who need a systemic treatment, there is the development of systemic JAK inhibitors, and I will show you some data related to our data coming with the use of baricitinib combined with UV lights. Regarding ritlecitinib is now approved for alopecia areata, so it's a JAK3 and TEC inhibitors. It has been evaluated in a phase 2B in patients with vitiligo, with a surface area involved 4 to 50%. It was patients with active disease with different dose. So here you can see after 24 weeks, of course, it's a limited number of patients with the standard deviation are very high, but there is a significant differences between the use of 50 milligrams per day of ritlecitinib in patients with vitiligo compared to placebo, especially for facial lesions. And it was sufficient to go for phase 3 study, and now there is a phase 3 study evaluating ritlecitinib for patients with vitiligo. And here is some patients who got very good response with ritlecitinib after 48 weeks of treatment, even if it's not perfect. Another JAK1 inhibitor is called povorcitinib. It's also developed in other skin disease such as hidradenitis suppurativa niva. So it's a phase 2 study evaluating povorcitinib with different doses in adult patients with BSA involved more than 8%. And after 24 weeks, all the patients received povorcitinib 45 milligram or the highest dose 65 milligram. And here is a patient, so it was mainly patient with fair skin, and you can see that the patients were patient with very extensive disease. So the T-VASI at baseline was 25, which is very important, and large surface of on the face, facial VASI 1.3. So patients with very extensive disease. What is the result? You can see here that after 24 weeks, the patients who got facial VASI 75 with the highest dose was very low, 13 or 80%, but after 52 weeks, even if the number of patients is very low, you can see that it is a significant improvement, proportion of patients achieving facial VASI 75. Regarding T-VASI 50, again at week 52, there is a significant proportion of patients achieving T-VASI 50 with the dose of povorcitinib 45 milligram or 75 milligram. Here is some clinical picture of the patient receiving povorcitinib until week 52, and the tolerance of the treatment was pretty good. Another systemic JAK inhibitors is upadacitinib. Upadacitinib was evaluated in a phase 2 study with different doses until week 24, and then all the patients received the treatment at different doses until week 52. Again, a patient with very extensive disease, as shown here, with a T-VASI, mean T-VASI 21, which is very important. And you can see there is a high proportion of patients with what we call active disease. And you can see here the result. I only show results at week 52, and you can see that at week 52, between 39 or 54% of the patients reach facial VASI 75, and between 34% and 45%, depending on the dose, reach T-VASI 50, meaning more than 50% improvement of the T-VASI. Again, the upadacitinib, we know this treatment because it's now approved in atopic dermatitis, and the treatment was well tolerated and more adverse event in the highest dose compared to the 11 milligram dose. But what is really important, again, because I showed you before that the combination therapy is probably much more efficient, because just to remind you, all the data I show you was were with a treatment evaluated alone, with no association with systemic treatment, with narrowband UVB. Here, you can clearly see that the combination of phototherapy plus topical treatments, such as topical calcineurin inhibitors, here is a systematic review of the literature showing that the association of topical calcineurin inhibitor plus UV lights is probably much more efficient than the use of topical calcineurin inhibitor alone. There is also here is just a sub-study of the phase 2 study with topical ruxolitinib, and 10 patients received that did not respond with topical ruxolitinib alone received narrowband UVB, and you can see a patient who did not respond to topical ruxolitinib alone when he start narrowband UVB twice a week, he got very good repigmentation, and there is now a study evaluating the combination of topical ruxolitinib plus narrowband UVB 3 times a week to show that the combination therapy is probably much more effective than the ruxolitinib cream alone. And to finish, I would like to show you the data we generated with a combination of baricitinib plus narrowband UVB in patients with vitiligo. And we only including patients with active disease, I showed you before. So it's patients with truly active disease with different signs of disease activity. And we evaluated the combination for baricitinib or placebo plus a narrowband UVB for at least 9 months. So here is the design of the study. We included only patients with active disease and patients with at least BSA more than 5%. And what is really important is the disease design of the study. So from day 1 to week 12, the patient received baricitinib or placebo alone. The goal was to stop the spread of the disease. And then at week 12, all the patients received narrowband UVB twice a week for 6 months. Here is the patient inclusion, so small study. 37 patients received baricitinib plus narrowband UVB, and 12 patients received placebo plus narrowband UVB. So mainly female patients, mainly fair skin, and you can see that the patients got very extensive disease at baseline. First, I would like to show you this data. This data is related to the sign, the score of the activity of the disease. Very simple score. You count the number of location of the body with at least one sign of disease activity. The score is on 15. And you can see that after 12 weeks, patients who receive baricitinib alone reduce the score of disease activity by 30%, while in patients on placebo, these patients increase the score, meaning that we including truly active patients. And then here is a primary outcome, primary objective of the study. We found that the combination of baricitinib plus UV lights, you reduce the VASI score by 44.8% in patients received baricitinib, while in the placebo group, only 9% of the patients reduce got change in the reduce the T-VASI score. Sorry, the T-VASI score was reduced by 9% in the placebo group. Looking at the T-VASI 50, T-VASI 75, and T-VASI 90, you can see that more than 50% of the patients receiving baricitinib plus narrowband UVB got T-VASI 50 compared to only 9% in the placebo group. We got almost 27% of the patients who reach T-VASI 75. That means 75% improvement of the vitiligo on the whole body. And only 6% of the patient, 2 patients, reach almost complete repigmentations. And here is classical picture of patient with who got good repigmentations. The two panel below. Here, one female and one male receive baricitinib plus UV lights, and here in patients who receive placebo plus UV lights. And here, you can see very good repigmentation of patients after 36 weeks receiving baricitinib plus narrowband UVB twice a week. Looking at facial VASI, you can see that there is a 65% reduction of the facial VASI score in patients receiving baricitinib plus UV lights, while there is a 4% increase of the facial VASI score in patients receiving placebo plus UV lights. And you can see that almost 50% of the patients reach facial VASI 90, almost complete repigmentation, while only 9% in the placebo group. And here again, very good picture of patients who got very good response in baricitinib group, while in the placebo group, this patient did not get very good repigmentations. And we look at the score of impact on the quality of life, looking at the DLQ. Here you can see a reduction of the DLQ score in patients receiving placebo, baricitinib plus UV light, while in the placebo group, there is increase of the score at week 36. The treatment, there is no significant differences between the two groups. Just to say that there is one patient in the baricitinib group experiences embolysis, pulmonary embolysis. It was one female patient who had a previous history 10 years ago. She did not remember this event. 10 years ago, she had a venous embolysis. So here is the first report of the combination of baricitinib plus UV lights. Baricitinib shows stabilization of the disease, and in combination with phototherapy, baricitinib shows significant level of repigmentation. So again, it's really important to combine phototherapy plus anti-inflammatory drug in patients with vitiligo to achieve very good repigmentation. But it's not just JAK inhibitors in the development of vitiligo. There is also different treatment strategy in vitiligo. We can probably block different markers or signaling pathway in vitiligo, such as targeting the IL-15R is receptor developing by John Harris here, and we can block also receptors associated with marker specific of melanocyte specific T cells, NKG2D or CXTR3, but also we can also consider to target innate immune signals such as a type 1 interferon or targeting HSP17, but also we can maybe promote regulatory T cells. It's the goal of a phase 2 study in vitiligo. And also, we can also consider to use MMP9, what we develop at this time, MMP9 inhibitors in patients with vitiligo to avoid the loss of melanocytes. But again, I will finish with this. It's a very interesting data coming from John Harris, developing RNA interference-based therapeutics. It's a very small molecules to inhibit a signal. Here, they developed a small molecule to target JAK1, and this small molecule injected in mouse model depigmentations can block the infiltration of melanocyte-specific T cells, and they show that there is a very good role of this molecule to also dampen the inflammations in mouse model of vitiligo, and also in human skin. So here, just to show you, I hope I show you that vitiligo is a very complex and heterogeneous disease with a major impact on quality of life. There is development in vitiligo based on better understanding of the immune pathogenesis. It's really important to recognize patients with active disease. The goal of the treatment is to stabilize the disease, to repigment, and to maintain the disease. Therapeutic algorithms are now available and can be obtained and can be downloaded from PubMed, and there is a lot of development in vitiligo. I will just finish by presenting my colleagues. Here is our clinic, a dermatological department in the center of Bordeaux. Here are my colleagues seeing patients with vitiligo and assessing clinical trends in vitiligo. Here is my research colleague and all our collaborators working on the immune pathogenesis of vitiligo. So thank you very much for your attention, and I'm pleased to respond to any question. Thank you very much.
Thank you so much, Professor Seneschal. It was beautiful, and it was really nice to hear all of the, preclinical, translational, all the way up through the current clinical trials, and just seeing the results in the patients is just phenomenal. So we do have a question from Dr. Rasool from Pakistan. They ask, what is the best and most cost-effective with least side effects, specifically for treating skin of color patients for vitiligo? I guess in your experience, like what has been the best sort of bang for your buck, so to speak, for treating patients in lower resource areas?
Yeah, of course. Of course, in patients, it's based on the work of our colleague in India. They actually they have access to a lot of treatments they use for the patients, and it's always a combination. First, I think what is important is to consider always combinations of therapies plus UV lights. It could be also natural sun exposure. If the UV lights are not accessible, you can use sun exposure, and natural sun exposure, and the goal of this is to expose your skin to sunlight, and it could be limited time, and the goal is always to get like a pink color on your skin, and always you get your pink color of your skin, you stimulate the origination of melanocytes. So you can use also natural lights if narrowband UVB is not available. It's always to combine natural sun exposure plus anti-inflammatory drugs. Of course, what is less expensive, it's topical steroids, but topical steroids could be applied on vitiligo lesions, could be applied usually for a long period of time, because we know that for vitiligo it's at least 6 months of treatment, so you can apply every 2 days, for example. For some patients, I use it 15 days a month for 6 months. It's not very expensive. Of course, for the face, it's not so easy to apply topical steroids based on the side effects. So if it's accessible, we can use topical calcineurin inhibitors. For patients with active disease, I think systemic steroids could be used. I think it's always a gold standard for patients with active disease, not very expensive. Probably in the future, with the development, systemic JAK inhibitors will play this role, but of course, it's still a very expensive treatment. There is also the development of, there is some phase 3 study to help the regeneration of melanocytes, especially for patients with darker skin. The use of melanocyte stimulators, alpha MSH, and that there is like a phase 3 study in patients with dark skin in combination with UV light. If you could improve the disease. So there is some development that depends of the availability and of the treatment in some area in some countries. But probably the less expensive is topical steroids plus natural exposure. And then after all expensive treatment, topical JAK inhibitors plus narrowband UVB is probably the best.
Awesome. Thank you so much. Now we have a question from Ashwin. Are there predictive markers for active vitiligo?
Predictive markers, different from clinical markers, because clinical markers, as I show you, it's the presence of these confetti lesions, trichomeria, and trichromaria and communal phenomenon type 2B. For biological markers, it has been shown, but probably you want to respond, Julien, about that, and you have a very good experience about that, and I will let you because you have done some works on that, and some markers such as CXCL10, the level of CXCL10 in the serum could be something important to consider as a disease activity marker, but I'll let you respond to this question. Maybe you have some other markers.
That's very kind of you. I'm just an immunologist. I'm not a dermatologist. So, but I have studied the CXCR3 ligands quite a bit. And Dr. Seneschal is completely correct. CXCL 9, 10, 11 tend to be good predictive biomarkers of vitiligo severity and activity. And you can catch them in the serum, but if you're able to catch them in the skin, it can be a little more accurate. So, so we've used like blister biopsies in the past to do that. So thank you. We have another question. Seham asks, are there any pediatric vitiligo guidelines? And for example, could systemic baricitinib be used in pediatric patients?
Yeah. So it has been just published in the JAMA Dermatology just a few weeks ago about some guidelines of vitiligo in the pediatric populations. In my experience, because I'm seeing pediatric patients of vitiligo, the guidelines, the treatment is not really different from adult patients. Of course, for pediatric patients, we can, as in adult, use topical steroid for the body, topical calcineurin inhibitors for the face. But for the topical calcineurin inhibitors, we always use the 0.1% and not the 0.03%, the lowest dose. We always use with topical calcineurin inhibitors, pimecrolimus or tacrolimus, the highest dose. Because it's important, otherwise that doesn't work. And we can combine with UV lights. It could be natural UV lights. For the narrowband UVB, actually, for the recommendation of using narrowband UVB in pediatric populations, we can indicate, we can start the use, but it's for the age, it's when the kid is able to stay alone in the cabin of phototherapy. So it could be between 8 and 12 years old. So it's important to consider that if you want to combine the topical treatment with narrowband UVB, if the kids are able to stay alone in the cabin. For vitiligo, for pediatric patients with active disease, we can use also systemic treatment, systemic steroids, mini pulse. I use methylprednisolone, but you reduce the dose. For patients over 50 kilograms, I use 16 milligrams Saturday and Sunday. And for kids or for adults lower than 50 milligrams, I usually use 8 milligrams Saturday and Sunday for at least 12 or 24 weeks. Of course, for topical ruxolitinib, now it's only approved for adolescents, adults over 12 years old. For pediatric populations less than 12 years old, it's not really approved, but there is in the future there will be some study evaluating topical ruxolitinib for kids, so it will be important to consider that.
Awesome. Well,
and for baricitinib, it's not approved for vitiligo, so it's difficult to propose this treatment, even if it's now approved for pediatric population in atopic dermatitis field, but as it's not approved for adult vitiligo, it's not possible to use it for pediatric patients.
makes sense. Thank you so much for answering the audience questions. And thank you so much for giving Global Derm Talks today. Merci beaucoup.
Thank you very much.
It's our pleasure to have you here today. And thank you especially for doing this during Vitiligo Awareness Month. And we want to also say thank you to all the folks at the VPOC, the organization in Europe that helps vitiligo patients. So thanks, everybody. See you next time.
Thank you very much. Bye-bye.